Respiratory diseases are a major cause of mortality and morbidity worldwide, but the situation is not hopeless because most major respiratory illnesses are avoidable. Tackling the burden of lung diseases, tonight on Call with the Prairie Doc.
Health information based on science, built on trust. I'm your Prairie Doc host, Dr. Andrew Ellsworth, and tonight we will be talking about lung disease and answering viewers' questions. Lung disease refers to any condition that affects the lungs and can hinder the ability to breathe properly. Common types of lung diseases include asthma, chronic obstructive pulmonary disease, COPD, pneumonia, and lung cancer. Symptoms of lung disease can vary depending on the specific condition, but patients may have shortness of breath, coughing, wheezing, and chest pain. Smoking, exposure to air pollution, genetic factors, and respiratory infections are potential risk factors for developing lung disease. Like most health issues, a visit to your primary care provider is essential to help prevent further complications caused by respiratory issues. Tonight, we will discuss lung disease and take viewer questions. Thank you for joining our discussion. This evening, we are joined in the studio by Dr. Paul Berger from Sanford Pulmonary Medicine Clinic and Dr. Svien Senne from Prairie Lakes Specialty Clinic in Watertown, South Dakota. Welcome and thank you so much for joining us this evening.
Thanks for having me. Absolutely. Thank you for the invite.
You bet. You bet. Svien, tell us a little bit about yourself, please.
Oh, very good. So I was born and raised in Vermilion. It's quite awkward for me to sit here on the SDSU campus. It's the second time I've been here. It's the second time I've been on this show. Next time I'll be wearing my USD pin to feel a little more comfortable. But I went to Augustana for a year, and then we finished at USD and pursued medical education after that at LECOM, Lake Erie College of Osteopathic Medicine down in Florida. And then I completed postgraduate medical education at the University of Nebraska Medical Center, where I received eligibility for my boards in pulmonary and critical care.
Awesome. And then how long have you been in Watertown?
About 6 years, 5.5, 6 years now.
So, great. Yeah. Good to have you back in the area.
Thank you.
And Dr. Berger, Paul,
yes,
tell us a little about yourself too, please.
Absolutely. Well, I'm Dr. Paul Berger. I'm a pulmonary critical care provider at Sanford Health in Sioux Falls. I also have extended training and certification for doing interventional pulmonary procedures so that we're able to maintain congruency and help take care of patients so that they don't need to travel further away from the Midwest. I'm originally from Sioux City. I completed my undergraduate at Morningside University and then did my internal medicine training at the University of South Dakota Sanford School of Medicine Internal Medicine Residency Program. Did my pulmonary critical care and neurocritical care training at Kansas University Medical Center, and then came back to Sioux Falls to work with Sanford Health.
Excellent. How long have you been there?
I've been with Sanford Health just a little over 8 years.
Awesome. Awesome. Well, thank you both for coming on the show tonight. It's your first time on the show, right?
It is my first time.
Well, we will try to not take you down too much. No, I'm just
Thank you.
Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about lung diseases. Viewers can contact us 3 ways. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. So, Dr. Senne, what is your practice, what do you see a lot of in your practice in Watertown?
My bread and butter is probably asthma and COPD. I deal with quite a bit of sleep apnea, though I am not completely, I'm not sleep certified, board certified. I don't read sleep studies, but I manage a lot of sleep apnea and deal with a lot of pulmonary nodules and things like that as well.
Yeah. You know, we've been dealing with more pulmonary nodules now as we've been screening for lung cancer.
Yes.
And thankfully, this is something that not that long ago we weren't looking into very much.
Correct.
And so, lung cancer is one of the top cancers.
It is.
So tell us about how we go about lung cancer screening nowadays.
Excellent question. So I'm of the belief, and I think Dr. Berger here would agree with me, that lung cancer screening is quite important. All right, lung cancer is the second most prevalent malignancy and the deadliest malignancy based on number of deaths caused per year. The problem with lung cancer is oftentimes, unfortunately, patients don't have symptoms until it's metastatic or widespread disease, right? And when we find something when it's small and it's early, we stand a much better chance of treating it and extending life as long as possible. So lung cancer screening encompasses those people who have accumulated a 20-pack year smoking history. That's the number of years they've smoked times the pack per day that they've smoked, who continue to smoke or have quit within the last 15 years, and who are between the age of 50 and 80. And there's a little bit of disagreement about who's going to pay for stuff at 77, 78, whatever. But the smart people who made the recommendation said 80. Medicare pays for 77 in most cases. So if you're one of those people, you should go through a CT scanner. And in this country, we have access to all sorts of technology, and that's fantastic. I can put you through the donut of truth, so to speak, my funny name for a CT scanner, and see what's inside of you. Yeah. And I can't always explain what I can see, but I can see it, right? And unfortunately, only about 5 to 6% of people who are eligible for those low-dose CT screenings are receiving them. So that's one of those things that I think that this country, we could all do a little bit better at getting people involved in that. And those people who continue to smoke, those are, in my opinion, kind of the low-hanging fruit. We can spot those. We can smell them, right? We know they smell of cigarette smoke or they have tobacco standing, and maybe we should bring this up, or we've taken a thorough social history and we know that. It's those people who maybe smoked between 18 and 45, and then their kids started to get older and they wanted to be a better role model, and they finally quit smoking, and now they're 50 and they should have a low-dose screening CT scan to make sure that things are doing okay and we're not seeing any early signs of cancer. So if we find something on a CT scan, a pulmonary nodule, as we would call it, like Dr. Berger or myself can biopsy that, a number of modalities, and put to rest whether it's something we need to worry about or something we don't need to worry about.
Because that's the thing. Some of these little balls, little nodules, many of them can be benign and not cancerous. We can leave them alone and not do anything. So Paul, how do you know whether this is something we maybe should biopsy or we should just watch it, or how do you know?
Well, a lot of it has to do with the patient's background, what their exposures have been, what their smoking history is, and where they're from. So there's other components too, like gender and your background that take a portion of what you're taking a look at. Also, you're looking at, do they have any other imaging? Is there anything else that would apply or be applicable to their nodule development? Or is there something else going on? Do they have any other disease processes like inflammatory, infection, autoimmune processes that could lead to the development of lung nodules or changes to the tissue in the chest? And so it's important to have those people be referred and get into a monitoring and program where that nodule can be monitored and followed, and that patient can be maintained within an appropriate timeline so that they can have either a biopsy or continue having a discussion of, do we continue to monitor this? Is this really going to end up being a nodule that we need to be worried about? Doing calculations, taking a look at the overall risk factors and seeing what your risk is. Is it more than likely to be benign? Is it an intermediate risk nodule, or is it a high risk nodule that may warrant maybe a referral to a cardiothoracic surgeon for resection? Or, depending upon what their other comorbidities are, do you take a look at referring for early treatment from a radiation standpoint? So it's best for the patients, it's best for the providers within the region to be able to maintain those patients in a good, consistent monitoring program.
Yeah, we want to catch it early and deal with
Absolutely.
it early, and that way better chance at helping. Now, sometimes people don't want to do. I've had patients that say, "Well, I've had some X-rays and they were normal." But we don't really recommend x-rays for lung cancer screening. Why is that?
X-rays are not sensitive enough to see these small changes that we need to understand. Dr. Berger and I go after stuff, 6, 8, 10 millimeters. We're talking half an inch. I feel the urge to explain something if it's growing and has reached a centimeter or 10 millimeters. And so a chest X-ray just simply isn't adequate to see those changes. And so the low-dose CT scan really strikes a balance between exposure to radiation and gathering more information. So we don't really expose people to a tremendous amount of radiation. I've heard the quote before of the same amount of ionizing radiation on a transcontinental airline flight, right? And so we can run you through a CT scanner a whole lot of times before I worry about any kind of issue with that. So honestly, when I have conversations with patients, what I'm most forthright about is what are we going to do with the results? Not everything we see is going to represent something that is a threat, and we might have false positives. And then of course, I'm sensitive to the financial implications. I understand that when I make recommendations in my clinic, it usually has a financial implication to the patient. And so, if they're worried about that, I always encourage them to reach out to their insurance company and talk about the specific costs before they become engaged in that.
The other pushback I get when I ask patients if they want to do lung cancer screening with a CT is, well, I'm feeling fine. What do you say to that when they're like, well, I'm not short of breath, I feel fine, I don't need to?
Oftentimes you become symptomatic really when it's becoming more too late. And so if you are becoming symptomatic from a nodule that has grown into a larger lesion, a mass, then that skews your ability for treatment, that skews your ability for overall survivability, and it leads to increased morbidity and mortality from the overall process. So the earlier that you can get to a nodule that may be cancerous, then the earlier that patient, our loved ones, can start receiving treatment and have a better opportunity at a better quality of life and overall longevity.
Yeah. We'll get to some of our questions here. We've got some great people calling in with things. And this person asks, I've been asked by my doctor to take a pulmonary function test for some issues I have been having. What is involved with this test? And what does it show my doctor? What's pulmonary function test or spirometry?
So pulmonary function tests, in my opinion, include three components. First of all, spirometry, and then there's lung volumes, and then there's diffusion capacity. So spirometry is measuring how well air moves in and out, and it is what is needed to make the diagnosis of COPD. I love telling people they don't have COPD because it has a by-the-numbers definition.
And what is COPD?
COPD, thank you. So COPD is a chronic obstructive pulmonary disease. It's a problem getting air out, all right? And you should get about 70% of your air out in the first second. And if you don't, then you might have a chronic obstructive pulmonary disease. And so spirometry tells us how much air we get out in the first second, or the FEV1. And then there's a ratio, the FEV1 FVC ratio, and that should be 0.7, or there's other criteria that are a little bit beyond the scope of our casual conversation here. But you got to blow into a tube to be diagnosed with COPD. So spirometry is the first part. Lung volumes is the second part. That tells me how much air you can hold in your lungs, the capacitance, right? I can tell you if you have enough air in your lungs. I can tell you if you have air trapped in your lungs when you're blowing out, etc. And then the last part is the diffusion capacity. That's how well oxygen can go from the air side to the blood side. And that's a kind of a fuzzy number, to be frank with you. There's lots of variables there, but it's something that we measure. So when I tell my patients what are PFTs, I kind of joke, my respiratory therapist is going to put you in a plexiglass box and coach you into giving your best efforts into blowing into a tube. So they're going to put you in a box and yell at you to blow. And that's more or less the truth. It doesn't involve any tubes being inserted into you anywhere. The nose clamp, I've had people complain, is a bit uncomfortable, but you blow into a tube. If you're claustrophobic, these PFT boxes, the body plethysmography boxes, are generally fairly clear and open, so you have a clear vision. And if push comes to shove, we can forego other parts of the test and just go with spirometry, where we don't need to close the door on the box and things like that. In a lot of clinics in South Dakota, they just have this kind of hairdryer device that they blow into that's hooked up to a laptop. That's bedside or portable spirometry. That is very adequate for many healthcare settings, but for what guys like myself do, we like to get the three components. So.
Sure. So, COPD, chronic obstructive pulmonary disease, is often also from smoking. So here's another plug on not smoking because of lung cancer and because of COPD.
Correct.
And sometimes we hear chronic bronchitis and sometimes we hear emphysema and what are those and how do they relate to each other?
So chronic bronchitis and emphysema are in the compendium of COPD. I mean, obviously it's part of the overall definition, but chronic bronchitis is the process where you have a productive cough for at least 3 months over about a 2-year time span or over a length of time. And it usually involves an inflammatory response to the airways. So the bronchi, the bronchioles that have an inflammatory response usually is something that is encountered like tobacco smoke. Could be wildfire smoke, could be something that your body encounters and leads to that inflammatory response. Emphysema is more along the lines of also an inflammatory response, but it's more of a destruction of the tissue of the lungs itself that involves the little airbags at the end of those bronchioles, the alveoli. And so the emphysema component is more along the lines of the breathlessness with exertion and then eventually progressing into the breathlessness at rest that a lot of our patients may experience.
What can we do to help someone that has COPD?
First of all, if you haven't quit smoking, the single most impactful thing that anyone can do to impact their disease course and severity of symptoms is to quit smoking. Aside from that, we direct a variety of inhaled medications, and then there are a lot of pills and some injections and whatnot that we can talk about now as well. But really the cornerstone is a tobacco cessation, or if it's not related to tobacco, understanding what's causing that COPD, whether it's occupational exposures, other environmental exposures, genetic risk factors, or longstanding chronic asthma, and then directing therapy based on what we think the underlying etiology of the COPD is, and then based on the patient's symptoms and their functional status and what their lung function tests show.
Yeah, very good. Sleep apnea is a common condition that occurs when your breathing stops and restarts many times while you sleep. Daryl Hartman, a Brookings resident, spoke to Prairie Doc about his diagnosis and ongoing treatment.
Hartman says he started to experience sleep apnea about 25 to 30 years ago.
As my wife said, I could peel the paint off the wall. I was snoring that bad. There was nights she would sit up and make sure I took another breath because I'd pause that long. At that point, we knew I needed to take a look at it a little deeper.
Now retired, Hartman's sleep apnea symptoms began during his tenure as the Brookings Fire Department chief. He says sleep apnea affected that area of his life.
In that position, you have to be sharp. And I kind of toyed with my CPAP on and off for a while. And at that point, I knew I needed it, and it made a big difference. I remember going to the doc and we talked about it, scheduled what they call a sleep study. Went in, you get all these wires hooked up to you and they put a unit on and they tell you probably gonna wake you up several times during the night. Part of that is making sure they have the right type of face gear. But during that process, they're logging everything that happens. They're adjusting pressures to see what the best potential outcome would be. And honestly, that's the biggest step. It's a few hours one night or during the day. It's very simple. You lay there and go to sleep.
Hartman says having a face mask that is comfortable is very important, along with ensuring the air pressure is adjusted correctly.
Stay on top of it. It's great for your health. If you just put it off, it can have devastating effects on your health, not only day to day, but cardiac problems and those types of things too. It's simple. I mean, just go see a doc. That's all it is.
As a primary care doc, it is amazing the difference I can see in patients once, and you guys have seen it too, once we get someone diagnosed and treated for sleep apnea. What are some of the things you've seen from sleep apnea treatments?
I kind of joke about the non-consensual naps that a lot of my patients talk about. I'd like to sit down and watch something, but I wake up when I'm hungry or have to use the bathroom again and can't seem to stay awake, or I can't drive really long distances and feel confident. A lot of patients don't necessarily, the fitful, restless sleep is also something that I hear a lot about. And once you get people on a CPAP and get them habituated, which is sometimes a process, sometimes people take to it quite well, it works. And in my opinion, there's, for every 10 people wearing a CPAP, one of them shouts about how much they hate it, and lets their opinion be known. But there's a lot of people there's a lot of CPAP strap marks shuffling down the pews every Sunday morning that I notice, and they're not talking about how much they hate it. So.
Well, it just, sometimes they have more energy, sometimes they're sleeping better, they're not waking up hundreds of times a night because their airway got blocked, and decrease your risk of heart attacks and stroke, and helps your blood pressure, and to decrease the risk of dementia, and I'm sure you can think of some other ways too, but and it can take some time getting used to. But when they do get used to it and they like it, and then they go on a vacation and then they realize, oh my goodness, if they didn't bring it with them, they forgot they're not getting treated, and they feel worse. And so just another plug for sleep apnea. I don't know if you'd have anything to add, Dr. Berger, about it, but
I think there's a lot of downstream benefits that our patients may not necessarily appreciate and see right from the beginning. But it does take a period of desensitization or getting used to be able to use the CPAP as effectively for the treatments that you would need. And the benefits for not just the reduction of cardiovascular disease, stroke, but even simple things like not getting up in the middle of the night and having to use the restroom from the obstructions, or reflux that can occur. So a lot of those will ultimately improve, and for my partners who do sleep medicine, I think that's one of the key and beneficial components of managing patients with sleep disordered breathing.
I will put a plug, recently we do have FDA-approved medications to augment PAP therapy and promote weight loss, and that opens another door. Unfortunately, insurance isn't widely paying for this stuff at this point in time, but it's an option. It's an opportunity for those whose insurance covers it, to help them lose some weight, augment their PAP therapy. And the studies that support the indication suggest there's about a 20 to 30% weight loss over the course of a year on this medication, and in about 50% of the study participants no longer required a CPAP at the end of the trial. So I'm really happy to have something else to talk about other than wear your CPAP. In some people, in some scenarios, there are other things that we can do to help out. Yeah,
neither of you do Inspire.
I do not do Inspire, no.
Could you talk about briefly so people know it's an option instead of a CPAP?
Inspire is available at Sanford, and we work closely with our ENT colleagues. And that is a implantable device that provides electrical stimulation to the hypoglossal nerve, so that when you are in the process of going to sleep, you have the ability to be able to activate that device, and that device elevates your tongue out of the way so that you have unobstructed sleep. And so that's for patients who are above the age of 18, who have moderate, severe obstructive sleep apnea, and are intolerant of CPAP therapy or PAP therapy of whatever kind.
Yeah, I think all health systems have that.
Prairie Lakes is not installing that right now. I believe Avera is. Their ENT docs are, and for select people, it really works well. In clinical practice, I think that there are fewer patients than we wish who could qualify for it, as there are some BMI requirements there, some BMI stipulations. So yes.
Yeah, excellent. Well, we got some good questions coming in. This person asked, how long does it take, or how do you get rid of bronchiectasis? Could you explain bronchiectasis a little bit?
Bronchiectasis is a kind of a pathologic dilation of airways, and it's usually due to recurrent infections. And it could be related to an underlying genetic disorder, like, say, cystic fibrosis, but there's also other entities like non-cystic fibrosis-related bronchiectasis, which you could come around from different exposures, like chemical-like burns from chronic microaspiration, or if you have infections such as a certain type of Aspergillus infection or other recurring immune disease processes that can lead to situations such as breathlessness, the development of COPD-like lung physiology. And it can also lead to, as time goes on, further hospitalizations, requirement for antibiotics and other treatments to try to treat the underlying disease processes.
Yeah, very good. This caller asks, I have a persistent cough for months. What can I do for this?
Yeah, chronic coughs they keep me busy and they can be the bane of my existence. So chronic coughs, in general, I kind of break them up into 3 or 4 different buckets. We've got an upper airway, so rhinosinus disease, post-nasal drip. We've got lower respiratory or asthma, COPD, bronchiectasis, chronic bronchitis, other things like that. Aerodigestive access, so we've got people with reflux or esophagitis or other things like that that cause a chronic cough. And then there's neurogenic, and that's not to say that it's in your head, but just to say that the nerves in your lungs are misfiring and giving you signals that you need to cough when you don't. There's no real stimulus. So I drill down into those first 3 kind of buckets, the upper and lower and aerodigestive axis, and see if I have anything that kind of gives me a clue as to what could be causing it. In truth, by the time someone makes it to me with a chronic cough, it's honestly probably more than one thing, as many PCPs are quite good at treating 1 to 2 things at a time, or even more than that. But you know what I mean? You got to kind of break the cycle. So there are times where I start treating everything, and the cough stops, and we start peeling stuff back and seeing what it was. And there are times where we get back to nothing, and the patients aren't coughing. And I just say, we broke a cycle. Something got fixed and hasn't broken again, and we'll see how you do.
Yeah. As a primary care doc, I mean, it's an amazing number of times where, maybe an allergy medicine helps, a steroid nasal spray, Flonase, or trying an acid reflux medication, and even though you haven't noticed heartburn or reflux.
It can be an odd and atypical symptom of reflux. You don't have to have heartburn.
It's a long-term process, and it's a commitment between the provider and the patient.
Right. And that frustrates patients sometimes, for any issues. Like day one, unfortunately, we can't always figure it out, can't always find a solution, but we just got to process of elimination. So there's so many times too, I'm sure many of our viewers have experienced, you got some sort of a bad cold, got a cough, and that cough just lingers for what seems like months sometimes, and can. Why is that, and what can we do to help with that?
So when you have a respiratory virus or another airway infection, or maybe you've got an underlying development of asthma, because asthma can be involving the young, and it can redevelop as you get older in age. And sometimes those things can rekindle that prior airway inflammation. And so that is a tricky component. I, being an asthmatic, just got over having influenza A, and this has been a really tough flu season. Yeah. And so I can't tell you how many times I've been on and off different inhalers and prednisone therapies as being a practitioner who has asthma themselves. So that too can be a very frustrating and ultimate process of elimination. And this is also something that you just have to kind of instruct the patient and say, we're going to use a stepwise approach, and it is going to take time for that airway inflammation to improve. And I'll oftentimes be upfront and say it will take a while to improve, or you may have some other issues that we need to look into and evaluate you for.
Yeah, excellent. This person wanted to ask about histoplasmosis, and we don't see a whole lot of that around here.
Histoplasmosis causes spots in lungs that we biopsy sometimes because we're worried that they're cancer. Histoplasmosis is a fungus that comes from the environment. It comes from all these little prairie potholes that we've got up, at least in this neck of the woods, that fill up and dry out, and the wind never stops blowing, and we inhale it. and our body, histoplasmosis likes the environment of our lungs, and it sets up and it grows for a while until, in almost almost, in many circumstances, normal, competent immune systems can clear the infection, and you're left with a granuloma, a calcified calcified nodule in your lung.
One of those spots that we're seeing.
Spots, right. And if it doesn't contain calcium yet, it makes us nervous. If it contains calcium, I'm not so worried about it, especially if we've got a little calcified lymph node that's nearby. It all tells a good story. We see some more calcifications in the spleen, because sometimes it can go to the spleen too, and then we feel good about it. There are times where people do get sick, and we do treat with it, and usually the treatment course is kind of long, and the treatment does usually require some blood tests to make sure we're not hurting organs, livers, and stuff like that. But it's out there, and as long as the wind is blowing, people will get it.
Since we're going down the line of some of these more interesting ones, this caller asked about sarcoidosis of the lungs.
Sarcoidosis is another process that can affect the lungs or really any organ in the body. And it's a autoimmune-like process, but really the overall understanding of the development of sarcoidosis is not entirely well known. So there are cells within our body that help promote and also help fight inflammation. And there's also cells in our body that fight off infection. Our bodies get sensitized to something, and then that something leads to kind of a inappropriate response from the body. It's not a complete autoimmune-like response, but it is something that can lead to irritation or destruction of the tissue, including the lungs. It can also lead to enlarged lymph nodes in the chest, and it can be very frightening when patients find out that they have changes on chest imaging, because one of the things you have to worry about and watch out for is some kind of underlying malignancy or cancer. And so that sarcoidosis is one of those things that, as a pulmonologist who does procedures, it's one of those things that aside from diagnosing cancer, it's something I'm actually a little bit more happy to diagnose, because it doesn't mean that it's going to end up being a condition that will potentially lead to chemotherapies, radiation, large surgeries. It oftentimes is something that will take care of itself, or will need to be monitored over a period of time. But most often than not, my experience is that a lot of patients will live with this and not experience a lot of untoward results from having had that disease process.
Now, are you going to be able to tell from a CT scan or other imaging whether this is cancer or sarcoidosis, or are you going to need to do a biopsy typically?
A lot of it does depend on the patient's history and what their background is, what their exposures are. But in all honesty, there's a lot of overlap. And so regardless of age and regardless of exposures, because you can still have malignancies that are not lung, and 20% of people who do not smoke can still have lung cancers. You want to make sure that you're not dealing with a cancer that would need to be treated. So a lot of times those patients will go through and do some sort of a biopsy.
And how do you do that?
So the biopsy is depending upon where the area of interest is, and since we're pulmonologists, we'll just go ahead and stick to the chest. Yeah. It can be done bronchoscopically.
So down the tube, down the throat.
Yep. So ideally, the patient is maximally sedated or with general anesthesia. They have a protected airway, and then you can use a bronchoscope, which is a tube about 3 feet long with a light suction device and camera on it, and also with an ultrasound component to it, and go down and do an airway assessment, and then either biopsy the lung tissue itself or use the ultrasound to deploy a small needle and biopsy the tissue in those lymph nodes.
Is this a in and out same day procedure? Or?
It's a same day procedure. Obviously patients would need to have someone drive them to and from the hospital, and you need to have someone monitor you following the procedure to make sure that you're okay. But it is a same day procedure, and it's generally well tolerated.
And definitely probably a lot better than back in the old days when they didn't have the option of doing that and had to
There were a lot of people who got chunks of histoplasmosis and sarcoidosis cut out of their lungs before we had good biopsy modalities, and that's not uncommon. You still run across people these days who had their right upper lobe cut out in 1987 because there was a spot that got bigger on a chest x-ray, and it was fungus, it was histoplasmosis, or it was the granulomas that they think are sarcoidosis. And so there is a lot of overlap with this, and I agree. A lot of this has to do with patient factors, patient risk factors, and nodule risk factors, and a not so scary nodule in a scary patient probably needs to be biopsied, meaning a not so risky nodule in a risky patient kind of changes the decision calculus versus other scenarios.
Yeah. While vaping is relatively new compared to cigarette smoking, it can be dangerous to users, and the full side effects are still unknown. Dr. Jonathan Rice, a general thoracic surgeon at the University of Arizona in Tucson, spoke to Prairie Doc about the dangers of vaping.
I think the main things you're going to get are coughing, wheezing, increased mucus production, pneumonia, and then, because you cough, a certain subset of population are at increased risk for these things called spontaneous pneumothoraces, or that's a collapsed lung. And you're at very high risk for that in that population, which is usually younger, tall, and lean individuals.
Rice says the liquid within a vape is not regulated, so the extent of all the chemicals within them and the harm they can do are unknown.
You are introducing one particulate matter into your lungs, which is never a good thing, especially because as these things go to distal parts of your airway and they're irritants in your airway, they can cause long-term effects from local inflammation, right? And it's mainly the chemicals that are inside of the vape liquid. And like I said, there's thousands of chemicals that are in these things, especially when it comes to the flavored vapes. They get the flavor anyway. They try to absorb the flavor into the liquid itself. And so you end up with, metals, formaldehyde, diacetyl, all these chemicals that you really shouldn't inhale.
Common populations at risk for vaping are teenagers and young adults.
These are people who have never been exposed to traditional cigarette smoke, and they're more likely to vape than older populations. I think the thought process is you don't get the after smell that you did with traditional cigarette smoke. So you could vape and nobody would ever know it because your clothes don't smell like smoke. It's a tough topic, and I think we're just in its infancy. The prevalence of vaping, I think, is going to get much worse before it gets much better. And I think until some of the long-term effects come out, we are kind of stuck in this like, hey, we shouldn't do this, but there's no hard evidence that this is really terrible for you long-term. But the common knowledge of what cigarette smoke did to people's lungs should foreshadow what's going to happen to you.
Do you guys see problems from vaping in your practice?
Not every day, to be frank. At first, when I first got out of fellowship right before the COVID pandemic, there was these folks who had this, I think it was vitamin E acetate was put in some THC containing vapes or something like that, is the best we could figure it out. And that caused quite a bit of lung damage to a lot of young people, sent some people for transplants and things like that. I echo everything that was said on that previous segment, and my sentiment is if you're a vapor, if you participate in vaping, you are kind of assigning yourself to an experimental group, and I'll get to learn from you, but that's not an ideal situation. So.
Yeah. This person asked from Facebook, do people who vape have similar lung disease to cigarette smoking?
It's a different process. With cigarette smoking, obviously after you've done it for a certain number of years, you can start developing, more of the COPD components. With vape, you're inhaling a superheated chemical that's got THC components, maybe vitamin E, but until there was some regulation with the FDA, then a lot of those adulterants were unknown. And having taken care of a couple of patients recently, it's a process of elimination. You have to make sure, of course, that they don't have, an infection. But the after effects of having vape-related inflammation in the lungs can be pretty devastating. And so everyone has to be careful with what they obviously inhale. Cigarette smoking is obviously not good for you, and neither is vaping. To that idea too.
Yeah, and I know there's sometimes some people have used e-cigarettes or whatever to quit smoking, and some people have done that successfully. But sometimes people do that, and now they're just upping their nicotine.
Right. There's been some recent data that shows you're more likely to relapse back to cigarettes if you use e-cigarettes as a crutch to quit smoking. And you're right, you escalate nicotine habits. There are also some observational studies which have a lot of issues with them, but they're out there that observe people who smoke then vape have a much higher incidence of lung cancer and things like that. So it's just hard to tease out exactly what's what at this point in time. And I think that the best that us doctors can do is be truthful with that and say we're not sure what's going to happen to you in the long term, and it's probably not going to make things better for you.
As a primary care doc, I get to try to help people quit smoking, and they do, all different times. Sometimes it takes various efforts, and it helps to change your surroundings and change your habits and come up with a new plan and find an accountability partner to keep you on top of things. By the time patients have seen you, they've got some more advanced disease, but some of them are still smoking, I'm sure.
Absolutely.
What are some ways that you found to help get people to quit smoking?
Well, one thing that as the lung doctor, when I go in and see a patient in the room, they don't want to be degraded or felt like they're less than. Yeah, of course there's an issue with smoking. It's a horrible addiction, but we're not necessarily there to punish them for that addiction. And so a lot of that discussion is, identifying the things in their life that could be better if they didn't smoke, from a financial standpoint, from a health standpoint, but then also telling them that there are resources that are available, and that as part of that too, you can use a lozenge, you can use gum, but until you break the cycle of what it is that gets you triggered to smoke the cigarettes, then you're not going to set yourself up for success. In 2020, there was an article published by the American College of Chest Physicians that indicated that perhaps the idea of quitting cold turkey might be a good option because it sets the patient up for accountability. And as I've spoken with patients that I've diagnosed lung cancer on, they've said that the nicotine lozenges and things like that were difficult for them because when they had anxiety or when they put themselves into a difficult situation, that drive for smoking a cigarette was so profound that they were able to take a look at that aid that they were trying to use and say, well, it failed me. So in the overall discussion, I try to get my patients to a point where they're ready to want to take those next steps to quit, not just say, well, here are some aids, and here are some other resources where you can perhaps band together with other people who have, the nicotine addiction, but getting them to a point where they're willing to accept that they need to quit. That is the key.
They're going to need to do that.
Yeah. I echo Paul's approach. I don't want to make a patient feel like I'm scolding them or belittling them. My approach is generally a big smile and how can I help you quit smoking? What do we need to do to get you there? Because it's not good for you and it's gotten you into this office. You're getting more doctors because you continue to do this. So that's kind of the alliance building is kind of where I come from. And there are medications, oral medications and nicotine replacement that are FDA approved to help people stop smoking.
Each time you quit, your odds improve that it'll work. So just keep trying, right? And you may relapse.
Yep.
And that doesn't mean the next time you quit won't work.
Correct. 100%.
Absolutely. We've got some other great questions, and I want to touch on this earlier. And so we've been talking about lung cancer some, and then using e-cigarettes to quit smoking, other ways to quit smoking. But we barely touched on, this person asked, can you get lung cancer even if you do not smoke? What are some of those other reasons that people get lung cancer?
Well, there's roughly 20% of the waking population can develop lung cancer, either from a genetic reason or from other exposures that they've had, like, say, radon.
And what is radon?
Radon is a odorless, colorless gas that it's essentially radiation. It's a breakdown product that is also kind of prevalent in this area due to the underlying rock that we have under the areas where we live. But other things that can cause lung cancer too are metastatic disease from other malignancies. So you may not just have lung cancer itself, but you may have had a disease process spread from someplace else too.
Yeah. Are there any other exposures that can increase lung cancer?
Radon is the biggest one up in this neck of the woods. We have a lot of radon. You can look at the maps, Google radon, and the government puts out maps of prevalence. If you're building a house in the state of South Dakota, you might just put it in when at the time of being built, rather than wait to build it and test and see what's there afterwards. As mitigation systems are fairly inexpensive, especially when built into new homes. So radon is the biggest thing that I worry about, aside from smoking. Yes.
Do we see many genetic conditions?
There aren't so many genetic conditions that we can test for and identify. There are a few, but we know that some cancers, adenocarcinomas in older ladies, for example, 70-plus-year-old ladies, they seem to be kind of a genetically mediated issue, because they're slow growing and they pop up, and you zap one with radiation, then one pops up right next to where you zapped the last one, and they're not very aggressive, but they're there, and it's a genetic process driving that growth. So
now we'll do the popcorn round, where it gets a little random,
awesome.
But this way we can help get to some of these people's questions. This person's what is the difference between BiPAP and CPAP? 1 and 2 pressures.
Yeah.
1 pressure is CPAP, 2 pressures is BiPAP.
Yeah, so CPAP, we're a continuous pressure to help keep the airway open, where BiPAP, it's changing,
it's undulating
as you're breathing.
Right.
And is it responding to your breathing, or is it automatically doing it every 3 seconds or something?
There are different modes. There's a spontaneous time mode where we can start to give you a rate, and otherwise it just kind of follows you and targets to a high pressure and a low pressure. And what we're really looking for is kind of a mean airway pressure there. Long answer is that there are different kinds of sleep apnea, and some of them need CPAP, some need BiPAP.
Very good. This person asked about interstitial lung disease, and if it will ever get better, and if there's any cures or preventions out there.
It really depends on what the underlying issue with the interstitial lung disease is. So you can have, the
lungs are getting stiffer, right?
The lungs are getting stiffer, and the lungs are getting stiffer because of something that you were exposed to. So, the textbook of interstitial lung disease is about that thick. Mm-hmm. So, you could have hypersensitivity from a particle that you inhaled. You could have interstitial lung disease from smoking cigarettes or vaping. Mm-hmm. You can develop an organizing pneumonia. So for a lung doctor, pneumonia just means inflamed lung tissue. It doesn't mean that you technically have an infection. So you can have a lot of different reasons to have inflamed lung tissue or have architectural change of the lung tissue that can ultimately lead to the development of hardened, stiffened lungs that's called pulmonary fibrosis. So once you have the fibrosis, you can't necessarily get rid of that because the damage is done. But what you want to try to do is treat the underlying disease process so that you limit the further development of more hardened lung.
Yeah, excellent. This says, my husband is a 50-year smoker. He is experiencing difficulty getting congestion off his lungs by coughing up sputum. Will percussion cup be helpful? Does percussion therapy help?
Yes, bronchial hygiene therapy in general is effective. I can't tell you how often I tell people to make themselves cough stuff up. We've got all sorts of different devices to help clear airways, mucus and secretions from airways. Some of it's just kind of some mechanical percussion on the back. We have some fancy vests that cost as much as Honda Civics that we can put on people and shake the sputum out of them, and other devices that we can have people blow into. But yes, getting the sputum out is good.
So besides percussion and vibratory therapies, does humidified air help with that too, to help get it up or not?
Sometimes it does. Sometimes some of my patients find humidified air or simply saline nebs kind of add some volume and make things slipperier, if you will, to kind of get up. It's variable.
Yeah.
Well, if you use humidified air, you have to make sure that you maintain a clean machine.
Yeah.
Right.
You don't want fungus in your humidity.
This person said, I had COVID 3 years ago and still struggle with my breathing sometimes. Yeah. What are my options, or something I might have to manage long term? Long-term consequences from COVID. Do you guys see some of that?
Yes. That statement there is pretty common in my practice, to be honest with you. And sometimes we can identify abnormalities with the lungs, and sometimes we can't, truthfully. COVID changes a lot of things with us, not only our ability to breathe, exchange gases, but at the cellular level for muscles kind of changes the way oxygen can be used and limit people's ability to exert themselves and make them feel breathless when their lungs kind of work well. So I would approach it just from my standard pulmonary perspective. I'd make my respiratory therapist put you in a box and blow into a tube and send you through a CT scanner.
There's a lot of things that we do not know about the after effects of COVID, and those things aren't going to be figured out, if they will, until years, if not decades down the road. I know that there's a lot of studies going on taking a look at the post-COVID recovery process and the changes that have occurred to patients who have had COVID. But it also may not necessarily be a lung-related problem too, because SARS-CoV-2 affected a lot of tissue that didn't involve the lungs. So there's neurologic issues, there's other endocrine issues, there's cardiac issues. So it may not just be a lung-related issue too.
Well, in our final minute here, I guess to sum that up, or with COVID and influenza season just over, just curious, do you guys recommend a flu shot?
100%, yes.
I do. Absolutely. having just recovered from influenza.
Yep. Do you recommend a COVID shot?
For certain people, I do. I think COVID has changed, but I think that for certain populations, you should definitely protect yourself. Yes.
Yeah, we definitely see how it's higher risk for people that are older and with immunocompromising conditions, and do whatever we can to help boost the immune system is a good idea.
Absolutely.
Very well. Well, thank you so much for joining us here tonight. Our winner for our contest is Paula. A book will be sent to you shortly. We'll be back after this.
On Call with the Prairie Doc has been a leading source of health education for 22 seasons. Join us this season as we continue to provide health education based on science, built on trust. Follow us on Facebook, Instagram, YouTube, and TikTok to access the entire Prairie Doc library.
A big thank you to our guests, Dr. Berger and Dr. Senne, for volunteering their time to help us learn more about lung diseases and answering viewer questions. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok. Visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Discussing bowel symptoms contribute to hesitancy around broaching the subject with a healthcare provider, but GI issues affect more than 40% of Americans each day. Gastroenterology, it's a gut feeling. Next time on Call with the Prairie Doc.
My name is Dr. Tom Dean, and I serve on the Healing Words Foundation Board, the nonprofit organization that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,